All this is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So nowadays with the vaccines, we are hearing a lot about the Guillain Barre syndrome or GBS syndrome. I thought what we should do is we should look at the Guillain Barre syndrome itself and see what is the pathophysiology, what is the management approach, and what is the prognosis. So with this, we'll look at the vaccine caused Guillain Barre, if at all, in a separate discussion. Today, I wanted to talk about Guillain Barre as a disease itself. So let's start a discussion. I'm going to share my screen. So this is drbeen.com. Here is one reference from CDC about Guillain Barre syndrome. They are saying people who have previously had GBS may receive a COVID-19 vaccine. To date, no cases of GBS have been reported following vaccination in participants in the messenger RNA COVID-19 vaccine clinical trials. I think that this is an outdated information. One case of GBS was reported in a vaccinated participant in the Johnson & Johnson COVID-19 vaccine clinical trial, and so on. So slightly old discussion. We know that we are hearing about the GBS nowadays. So I'll discuss that separately. Here is Wikipedia about Guillain Barre. I have prepared Guillain Barre from Robin's Pathology. So if you want to hit some medical book, this will be Robin 9th edition. Here is the disease description and pathophysiology. So totally up to you. This is the ganglioside and the reference to this. What is ganglioside? We're going to look into that in our discussion. So with this, let's start our discussion with my illustrations. So Guillain Barre syndrome is defined as, and there are many definitions, but generally it is a disease that is rapid in its onset. So it is rapidly developing disease. It is a disease that causes demyelination of the motor neurons, mostly motor neurons. There are variations of this disease where sensory neuron may be damaged as well, and it can lead to death. So that is the basic definition. The prognosis is bad. So the death occurs in about 5 to 7% of the patients. Majority of the patients, when provided enough support, will recover. And then another majority in the recovered will recover fully. Some of them will have some remnants, and I would discuss later in this discussion why some folks continue to have symptoms afterwards. Now, usually it is treated with plasmapheresis, that is plasma exchange, or with the intravenous immunoglobulins, or with both. Steroids have not been found to be very helpful, and they have delayed the recovery from Guillain Barre. And of course, supportive care will be needed, and we'll discuss why supportive care. Some of the patients will end up in ICU because of the muscle paralysis, and especially muscle paralysis of the throat muscle that would make it difficult for them to swallow, and that can cause the food to enter the respiratory pathways, causing death, or the respiratory muscle paralysis that can also cause death. So it is possible that patient might need ICU support. Now, what is Guillain Barre? So if you are just interested in understanding what is the summary of Guillain Barre, that is it. We're done. You can you can leave from here if you want. But if you are a medical professional or you just want to understand what is the pathology of this disease, then we're going to go into detail now. So here's a detail. Let's start from this little diagram in the center. We have a segment of the spinal cord here. Spinal cord is, of course, we know that it is a long column of nervous system tissue in our vertebrae, passing through the vertebrae. This tissue, if I take a section of this tissue, that section looks like this. In this section, what you see a frontal part of the spinal cord, or ventral part of the spinal cord, and then of course there is a dorsal, or the posterior half of the spinal cord. Why do we separate spinal cord in these two halves? They're not exact halves, but still an anterior part and a posterior part. The reason for that is that anterior part of the spinal cord is mostly related with motor activity and motor neurons. This is one of my favorite topics, the neurology. So I love these discussions. So the front. So imagine if I hold something here which is circular, don't have anything. So imagine a circular uh, cylindrical structure. In that cylindrical structure, imagine it is filled with the neurological tissue or nervous system tissue. The anterior part of that tissue is motor part. Motor part means it is made up of nerves that will relay mostly on muscles, and when there is nerve signal in those nerves, that would cause some muscle to function. For example, this my hand, I'm moving my fingers. This movement is because of the signals coming to my muscles of the fingers through motor nerves. The posterior part of the spinal cord is related to sensory nerves. So if I touch my hand here, the sensation from my hand, the skin of the hand, will pass through a nerve all the way up to my spinal cord. And that nerve that is carrying the sensation will enter the spinal cord from the spinal cord's posterior side. So we say that the dorsal side is sensory and the ventral side is motor. This is very important to keep in mind. The disease we are talking about today, Guillain Barre syndrome, is primarily a disease that affects the ventral side of the spinal cord and the neurons. That means it would affect the motor part of the neuron or motor neuron, and usually the early beginnings of the nerve, which is called radical side. Radical side is where the nerve is coming out of the spinal cord. So we have radiculopathy. That means the root of the nerve when it is coming out of the spinal cord, it is inflamed there. Plus, the early segments of the motor neurons are inflamed. So that is the basic area that we are focusing on. So we're going to go from here. This is like if we take a helicopter and look at it from a 20,000 feet. And now I'm going to continue to drill down till we reach a microscopic level so we can understand where the damage actually occurs. So now we know highest spinal cord. This is a section of spinal cord. This is a motor neuron. We are concerned with this motor neuron. Now let's continue. Here is a diagram of a motor neuron which is naked. It is not wearing any clothes. That is why it is kind of looking so happy, but it could have been a little embarrassed as well if it could use that expression. So let's look at this neuron. So here is the neuron's cell body. So this is also called soma. On the cell body of a neuron, there are signals that are coming to this neuron. Those signals arrive and they relay on dendrites. So neuron has, the cell body has small branching filaments coming out of it. These filaments are called dendrites. They are tiny, they're small. And on the dendrites, other axons or arriving signaling tissue that relays there. So simply what we are saying here is we have a cell body. The cell body has dendrites on it. Those dendrites are receiving the signals. You can call them the ears of the axon or the neuron. Through those ears, it is listening to the signals. Then the neuron would send a signal out. So imagine, think about it, my neck here. I want to move my hand. So on my neck, brain is sending a message on the tissue of my neck. Brain is sending a message to say, hey, Mubin wants to move the muscles of the hand. Now that signal will arrive in the neuron that lives in the cervical spinal cord, in my neck spinal cord, and it would end on that neuron at the dendrite here. Then that signal will have to now travel from that neuron all the way to the muscle of my hand, and it would move the hand. So this outward travel of the signal which is going to the muscle. So imagine this part, this grayish, brownish part, this is muscle. So the part of neuron from the spinal cord, the wire that takes the signal to the muscle, that is called an axon. That is called an axon. So neuron has a body, dendrites to receive the signals, and then a long wire or neuron, which is called axon. Neuron, this whole structure is called neuron. So this is the axon. Now the problem is this: why is it naked here? I wanted to make a point. What happens is that when the nerve signal travels through the neuron, it eventually ends up at the end of it. That is called the terminal part of the axon. This is just like this: if we have wires at our home, and then there is an end of the wire that ends up in a bulb or in a fan or TV or something. So that last part is called the terminal part. The axon's terminal is swollen, it is a little dilated at the end. Why is it dilated? Because most of the time it has chemical substances in it. When the nerve signal arrives at the end, the chemical substances are released from this end, and they are poured on the muscle. So this area of the muscle where a nerve comes and attaches or relays, as we say in medicine, that area is called, or this whole structure is called neuromuscular junction. There is a nerve here, there is a muscle here, and there is a junction here. This is an NM junction or neuromuscular junction. This part of the muscle is specialized. It is called a motor end plate. Why is it called a motor end plate? Remember, this neuron is a motor neuron, and this little bulb-like thing is the end of the neuron, and then it is finishing on the muscle's area, which is kind of flattened. So it is a plate-like structure. So this muscle structure is called motor end plate. This whole structure together is called neuromuscular junction. And the function here is to bring the nerve impulse and move the muscle. This is where an electrical signal is converted into a mechanical signal. Just like we have machines where you give them electricity and the machine runs or operates, and we have converted electricity into a mechanical outcome. That is similar thing that happens here. This is called transduction. Transduction means one kind of signal converts into a different kind of signal. Here, an electrical signal is converted into a mechanical outcome. Anyways, we still are kind of curious, why is this neuron naked here? Why did I draw it naked? Here is the reason. These neurons that are bringing messages for imagine a neuron going from the spinal cord, lumbar area, the lower part of our back. From there, a neuron going, axon going all the way to the toe or the muscles of the feet. Imagine how long that wire is. So imagine now, if I want to move my toe, what will happen is I will think that I want to move my toe. Then the brain will send a signal to the spinal cord, to the neurons in the spinal cord, lower part of the spinal cord, and say, hey, Mubin wants to move the toe muscles. The appropriate neuron there will send a signal through their axon all the way to the muscle of the toe. And then when that muscle of the toe will receive the signal, it will contract and I'll have toe moving. This can take time. So how weird will it be that if I think now that I want to move my toe and about a second later the toe moves? That would be bad. And it happens in patients. Why is that the case? That is the case because the nerve signal transmission in a naked nerve is very slow. The speed of transmission or velocity of transmission inside a nerve depends upon many things, and this is important from a healthcare professional's point of view. For example, the diameter of the nerve. The bigger, fatter, the greater diameter of a nerve, the faster the impulse goes. The number of channels in the nerve. More channels, faster the conduction. The correct electrolytes availability, sodium, potassium, calcium, the electrolyte levels, the faster and correctly the conduction would go. And then a most important thing, and that is if the axon is wearing clothes, then it would perform faster. So let's look at that. I'm going to use the same axon, but I'm going to bring some clothes on it. What does that mean? Here, if you see these blue things, the hot dog looking things, these are actually wrappings on this axon. Just like, electrical cables have that plastic covering on them, it is a similar covering on the axon. I have a reason that I'm mentioning this all. I'm going to connect it to the GBS. So there is this covering on the axon, and what happens is presence of this covering allows the nerve impulse, the electrical signal, to jump between the empty areas and run fast and end up at the nerve terminal. This is called a jumping type of nerve signal travel. And the signal jumps, let me make it in a different color. The signal jumps from one node, these gaps between these blue things are myelin sheaths. The gap between the blue things is called a node of Ranvier. It is called a node of Ranvier. The nerve impulse jumps from one node to the next, to the next, to the next, to the next. And it runs very fast. So this myelin sheath over here, it is made up of Schwann cells. And the function of the myelin sheath is not just to provide electrical covering, but really it provides a way for the impulse to jump through the nerve. And that causes a greater speed. Now think about it for a second. If I have the axon from my spinal cord to my toe, it's a long axon, and it is all covered with myelin. So when the nerve signal is going through this, it is jumping from one node to the next node. And imagine if that cell there, it gets damaged. The myelin sheath, the covering gets damaged. What will that do? That will make the axon naked again. If not all of it, then part of it. And now what would happen is, imagine there is covering here and covering here. In between, the covering has been destroyed. And now the nerve signal will jump from here to here and then walk very slowly through this, jump from here to here, and then walk very slowly through this. That would cause a slow conduction in the nerve. That would mean if Mubin said, I want to move my toe, it might take a second for me to move it. But there is another problem. The other problem is some nerves have their covering damaged and some do not. So imagine these two fingers, I'm raising two fingers if you can please see me. They both are muscles. And imagine one muscle is receiving a nerve which is not damaged, and the other one is receiving a nerve which is damaged. When I'm sending a message to both of them together to move my toe, for example, but one of them got the signal before and the other one got it a little later, then what would happen is one muscle will move, other is still not moving. So I will get an uncoordinated movement. That uncoordinated movement can cause severe damage, it can cause imbalance, it can cause incorrect function. And if the nerve is so much damaged that the signal does not arrive at all, then these will not move. And now imagine if this muscle is actually not the muscle of the toe, instead it is the muscle of my vocal cord, or my throat for swallowing, or my respiratory muscles. If they don't work, they can kill me. Their absence of their function or incoordinated function can kill me. So this is really important to note, that we have myelin sheath and we have Schwann cell. Now we have to understand the Schwann cell a little more. This is the cell that makes the wrapping around the axon of a motor nerve and actually a sensory nerve as well. This is the sheath, this is the covering that makes the nervous system tissue look white. This is why we say the nervous system tissue is of two types: gray matter and white matter. This covering is white in color when seen under the microscope. So here there is a cell called Schwann cell. Schwann cell makes a wrapping around the nerve. The Schwann cell itself, if we look at this side here, this side, Schwann cell is a regular normal cell. That means it has a cell membrane which is made up of phospholipids. All cells have a membrane, and that membrane is made up of a bilayer. That means two layers of phospholipids that make the barrier. This is like if you think about a ball, the leather of the ball is phospholipid. In the nervous system tissue, the phospholipid, about 5 to 7% of phospholipid is made up of a special kind of phospholipid called ganglioside. So just imagine that nervous system tissue, Schwann cells and the axons and the other neurons and other nervous system tissue, their phospholipid have a specific lipid type in them, or phospholipid type in them, which is called ganglioside. This ganglioside structure, molecule, becomes a target of antibodies, which can be generated by vaccines or generated by pathogens like Campylobacter jejuni or cytomegalovirus or HHV5 or HIV and so on, even SARS-CoV-2 vaccines. So once those antibodies attack this ganglioside, they destroy this cell. When they destroy the covering cell, whose job, the cell's job, is to create a rapid transmission of nerve signal. So when that cell is destroyed, nerve signal becomes incoordinated, as I just discussed before. That is what is Guillain Barre. One type. I would discuss more types. So for now, we have a neuron, and that neuron has a myelin sheath on it. Okay. Moving forward. Type of Guillain Barre syndrome. There are 4 or 5 subtypes, but I want to discuss in 2 main classes. One type is where the myelin sheath, it is called demyelinating type, where the myelin sheath, this yellow thing, is attacked by cytotoxic T cells of the immune system. Remember, we have been doing immune system forever now. We have a T helper 2 pathway that makes immunoglobulins or antibodies, and we have T helper 1 pathway that activates the cytotoxic T cells. So if this sheet is attacked by cells, then that is called a demyelinating type of the Guillain Barre, although demyelination occurs in both types. But if this cell is attacked by antibodies, then it is called an axonal type of Guillain Barre. But generally for us, it is sufficient to note that Guillain Barre has damage to the myelin sheath or Schwann cells, and the Schwann cells can be damaged either by the cells of the immune system or by the antibodies that immune system produces. So both can occur. So now let's see what is that mechanism. So we have seen this before as well. Let's start from the left side. Imagine somebody is infected with Campylobacter jejuni. Although it is interesting that people who are infected normally do not develop GBS, but people who have GBS, they also have Campylobacter or cytomegalovirus or HHV5 or HIV or some vaccine. For example, flu vaccine can do this. And nowadays there are reports that SARS-CoV-2 vaccine can do this as well. So a pathogen here or a vaccine here. We know that the vaccine would enter, messenger RNA vaccine, lipid nanoparticle, will enter into a macrophage, or a macrophage would eat up the pathogen, whatever is the process. Eventually, the macrophage is going to present the antigen to naive T cells. So this is a naive T cell. Naive T cell can go the T helper 2 pathway, where it will become converted to T helper 2 in the presence of interleukin 4 and absence of interleukin 12. T helper 2 will then activate B cells to make antibodies. These antibodies can attack attack the myelin sheath or Schwann cells and kill them. Or this naive T cell can go T helper 1 pathway and eventually activate a cytotoxic T cell or CD8 plus T cell, which would then go and kill the Schwann cell by directly attacking it. So either get attacked by the antibodies from this pathway or attacked by the cytotoxic T cells from this pathway. Both pathways can attack the myelin sheath. Now what happens? So just to refresh, this is the myelin sheath, the yellow one. And so let's look at the first pathway. Here we have the cytotoxic T cell. This is T helper 1 pathway, or a macrophage, innate arm. So here the poor person, their myelin sheath is being attacked by both the innate arm and the adaptive arm. So here is a macrophage, or here is a cytotoxic cell. The system, the immune system, produces complements. We have done this discussion before. A complement is a protein produced by liver in response to acute inflammation in the body and some pathogen in the body. That complement, the function of that complement is to coat the pathogen and make it yummy for the macrophages and other cells to eat it up, to destroy it. At the same time, complement activation also causes holes to be formed on the surface of pathogen and to destroy that. Here, when this complement is activated, that complement can settle on the Schwann cells. That is our cell. And the complement settles on that. When the complement settles on our Schwann cells, then what happens is a macrophage would look at complement wherever it is and attack that place. And so macrophage would attack the Schwann cell and destroy it. That would remove the clothes from the axon. That would slow down the nerve conduction. Similarly, the cytotoxic T cell can make holes. These white little things are the holes in the Schwann cell. And then the granzymes, or the cytotoxic proteins, are thrown in the cells like grenades, and the cell will be destroyed. So here the only bad thing is this is our cell. This is our Schwann cell. We don't want it to be destroyed. But these two cells, macrophage and cytotoxic T cell, they ganged up and they killed it. So the end result is going to be an axon whose myelin sheath covering is damaged. Continuing on, how does antibody cause the damage? So when a pathogen arrives in our body, for example, Campylobacter or cytomegalovirus or HIV and so on, or when there is a vaccine, for example, flu vaccine and now SARS-CoV-2 vaccines as well, these can cause molecular mimicry. And what does that mean? That the pattern on these pathogens or vaccines can create antibodies that are supposed to attack those pathogens or vaccines, but that pattern looks very similar to gangliosides on the nervous tissue. So those antibodies would start attacking the gangliosides. Now, gangliosides are the part of the cells. Now on the axon, the cell that is wrapping is myelin sheath cell Schwann cell. So when antibodies would attack the Schwann cell will be destroyed. So once again, here antibodies arrived and destroyed the cell. Then what happens? Once the cell is destroyed, the Schwann cell, so imagine this is the neuron, this is the axon of the neuron, and here this is damaged Schwann cell. And here, if you see this part, there is no Schwann cell is gone. There is no Schwann cell here. There is no here. There is none here. So these Schwann cells are gone. So one issue that appears is that when Schwann cells are gone, the nerve conduction becomes bad. Second issue is, and this is important, I had said in the beginning of the discussion, I will explain why some folks continue to have issues even after recovery. And the reason is, here, check this out. There was no Schwann cell here, got damaged. When it was reproduced, when it was healed, the new Schwann cell is not as big as it should be. It is smaller. So it is not really covering the nerve correctly. Or instead of making one Schwann cell, there are 5 Schwann cells in that small part. That means nerve cannot jump through one 10-meter jump. It is making one every 1-meter jump. So it is still going slow. So either the Schwann cell produced is incorrect, or too many Schwann cells are covering now that same area. There is onioning of the Schwann cell, as many Schwann cells start wrapping each other around and make an onion over there. All of those abnormalities can then cause a person to have a lifelong abnormality in nerve conduction. Majority of the people would recover fully. 5% can die. And then those who have recovered, in them, a minority might not recover 100% because their myelination recovery is not 100%. Now, how do we manage these patients? So acute, remember, it is an acute, rapid, progressive demyelination. That means it can kill if we don't get ahead of this fast. Now, there is no management directly to reduce the speed of Guillain Barre, or to reduce the production of antibodies, or to stop the cytotoxic cells from damaging. So we have to wait for these immune system reactions for about a couple of weeks to occur. Meanwhile, we have to keep the person alive. We have to keep supporting them so that the storm of immune system's misbehavior goes away and then they recover. So what are the things that can be done? Number one is plasmapheresis. In plasmapheresis, what we do is we take the person's blood out of their body. We bring it in a machine that separates the blood cells from the plasma of the person. The plasma contains the antibodies that are attacking their Schwann cell. So we want those antibodies to be gone. So what we do is we separate the plasma from their cells. Then that plasma that is separated is thrown away, but now we have removed so much fluid from there. So what we do is we replace that fluid with normally 5% albumin. We bring the blood out, we separate the cell, we mix the cells with albumin and put that back. The plasma is removed and thrown away. That is how we remove the antibodies and we reduce the attack on the tissue. And we keep doing it till that attack stops. The other thing, for which we do not know exactly why this helps, but intravenous immunoglobulins help as well. They help filter out or clear out these antibodies. Exactly what is the mechanism is not known. In addition to that is a supportive treatment. For example, if the person cannot breathe because their respiratory muscles are not working correctly, then they might need ventilation. Or if they cannot swallow, then they may need a nasogastric tube for helping with the nutrition and so on. So the person may have to be admitted in ICU and supported there. From a diagnostic point of view, diagnosis is a combination of clinical and some of the other tests, but majority is clinical. So clinically, rapid development of muscle paralysis. Usually it is an ascending type paralysis, meaning it starts from the toes and legs, or from the hands and arms, and then just moves towards the center. If it reaches the respiratory muscles, then the person can die. So it is a rapidly progressing paralysis of the muscles, usually in an ascending fashion. There is absence of reflexes. And absence of reflexes is actually very simple to understand. If I go here, so let's say this is a spinal cord, and we know the ventral side is motor, the dorsal side is sensory. And let's say we attach, this is a piece of skin from which this sensory nerve is going to the spinal cord. Imagine that this is the skin on my finger. So when we prick this area, so let's say there is a pin and somebody touches my finger with that pin. When we prick this area, or we cause sensation here, then the sensory nerve signal will travel all the way to the back of the spinal cord. From there, from the posterior part, this signal will go up either on the same side or from the other side or from the same lateral column, many ways. But it would go up to the brain so we can feel that sense. But at the same time, this signal will move from the posterior side of the spinal cord to anterior and become continuous in the motor signal. So motor signal is going to a muscle. That means, like an electrical switch, if you touch the skin, you'll have the motor muscle move. That means every time you, let's say you touch my finger should move. It does not happen because our higher centers, our brain, normally keeps these extra reflexes in control. But you must have seen that when you go to a doctor, they would take a hammer and kind of do a knee reflex. And what happens is they hit the tendon, and that causes muscles to move. This is that mechanism. Now imagine that this motor side is not working correctly. So if you touch this switch over here, the sensory side, that nerve is not able to travel all the way back to the muscle, so reflexes will not be present. So many of the neuronal damages cause reflex to become less or uncoordinated or be abolished altogether. So there is absence of reflexes. There is usually no fever, and there is usually no other cause to be seen for the paralysis. Lumbar puncture studies can be done. Usually within first 2-3 days, the proteins are higher, about 50% higher than normal. About first 2 weeks, proteins are higher, about 80%. But as you start giving medication, that can also increase the proteins. So not great, but still an important thing here is in the CSF, proteins are increased, but white blood cells are reduced. Normally, when proteins increase, white blood cells are also increased because white blood cells are making antibodies, for example. And so more cells, more antibodies, proteins are more, cells are more. Here in Guillain-Barre, the proteins are more and cells are less. So there is a disconnect between the proteins levels and the cell levels. This disconnect can be used to differentiate Guillain-Barre from other paralysis pathologies. Anti-ganglioside antibodies can be measured, but still anti-ganglioside antibodies are not very useful because they could be present without much damage. Then blood test can be done. Normally in the Guillain-Barre syndrome, sodium level is less, and that is less because the pituitary is not working correctly, and so we're not able to retain our sodium correctly in our kidneys. Usually potassium levels are correct, but we should do blood tests to make sure that the paralysis is not because of less potassium. And if that is the case, then it is not Guillain-Barre, it is just the potassium. So this is the discussion. I hope it makes sense, and I hope my audio was working. It would have been funny if I kept speaking for an hour without an audio. Okay, so I'm hoping that the audio was there. Please do me a favor. So let's see if there are any questions. Arun has a question. Uh, as motor neurons don't have myelin sheath, they are not affected by GBS. Am I right? No, no, no. So I made them naked to show that if they do not have a myelin sheath, they don't work correctly. All motor neurons have myelin sheath. Motor neuron must have a myelin sheath, otherwise they cannot function correctly. So my apologies if I gave the other way around the impression. The problem is when you damage that myelin sheath, then they don't work correctly. Roller Girl is here. Hello, Roller Girl. It is 41 minutes. Jody says, does ivermectin help rebuild nerve cells? It's what I heard, I think, here. I will have to check that up, but ideally, other than helping with the inflammation, it would not help rebuild it. Absolutely. So, Tim Wong, the dysautonomia actually is part of the Guillain Barre as well. In some people, dysautonomia causes the heart rhythm problems, GIT rhythm problems, can cause diarrhea, can cause tachycardia, even the ocular muscle reflexes can be affected by that as well. So dysautonomias are also can be caused by Guillain Barre. Very good question. So it can be autonomic, it can be Guillain Barre as well. Okay, very good. So Colin says that he can hear me. Excellent. Audio, video, great. Awesome. Good to know. This is the newer computer, so I just become. Remember, I don't know if there are cool beans who remember once I delivered a complete lecture without any voice, and people kept saying there is no audio, and I kept just teaching, and then I did that talk once more. Okay, cool. So do me a favor. Um, Abhijay says, is this different from MS? Yes, multiple sclerosis is different from Guillain Barre. That is also a chronic situation. That also has demyelination in it. So with this, let's do this. Please do me a favor. Please like, subscribe, and share. And if you would like to support this work, there are 3 links in the description. You can support it by buying me a coffee or by using PayPal or by becoming a patron. So thank you very much. And I would see you in a few minutes.